Now you can start.
Okay. Hi, everyone. I welcome all of you today from Papana, Pakistani American Psychiatric Association of North America. Papana has brought you a series of lectures and a study group on psychopharmacology. This is our sixth lecture of the psychopharmacology lecture series. This is conducted by CME, Education Committee of Papana, in collaboration with ChemPsych, which is King Edward Medical University Psychiatry Interest Group. The topic of today's lecture is nuts and bolts of psychopharmacology, which is an introductory discussion on antidepressants. Um, and the topic is, can mechanism-based learning optimize antidepressant response and tolerability? And we will be learning about all the neurotransmitters and transcriptors and their action on the various receptors and the role on neuropsychiatric drugs. So today's lecture is given by Dr. Mujib Shad. He's adjunct professor of psychiatry and residency director at the Toro University of Nevada and the University of Nevada, Las Vegas. He will take you step by step through this process. Dr. Shad is the recipient of the Best Teacher of the Year Award by the PGR3 residents at Samartian Psychiatry Residency. And I am pretty confident you are going to enjoy this lecture. So,
Yeah.
yes, please.
Thank you, Fazia. Thank you so much for a very kind introduction. I think you have said it so many times now the people will remember by heart. Uh, I think if these are the same audience,
Yes.
they will say,
No.
yeah.
Every time there are new people coming up. Every time.
Yeah. Okay.
Mm.
Thank you so much. So
Yeah.
let me share the slides, the screen, I mean to say. And yeah, can you see it?
Yes, Professor Shah.
Yeah. Thank you. So basically, welcome everybody. I'm really appreciative that Dr. Numan Ashraf is here, who is a very experienced program director, and I'm honored to have him here on my presentation. I hope he likes it because he knows a lot about psychopharm. Okay, so let's start with the where we ended last time. I think it was after citalopram. I think we finished as the discussion of the major discussion of SSRIs, but I think I was going to begin with the adverse effects of SSRIs, right?
Yes,
Yeah.
Professor.
Okay. Yeah. Okay. So let's move on. We talked about this. Okay. I think one of before I think I should not move. I should not skip this slide because it's a little bit untimely. But I didn't want to take it out because a lot of times we forget to talk about how to switch between antidepressants. And I think it's very important point to remember is that when you're switching between antidepressants, you should look at the class of the antidepressants you're switching from and to, both of those. And I think the biggest concern is switching between SSRIs and switching them to monoamine oxidase inhibitors, one of the monoamine oxidase inhibitors. And that, if you are not following the guidelines, the patient may end up with the serotonin syndrome and other adverse outcomes, which can be clinically serious. So basically, what the recommendations are that if you are switching from SSRI, you also need to be careful about the half-lives of the SSRI you're switching from, because if SSRI has a longer half-life, such as fluoxetine or Prozac, they're going to, you will require a longer period for discontinuation of fluoxetine or Prozac, and then start monoamine oxidase inhibitor. So the recommendation is that you wait for about a week for most drugs, including SSRIs, but for fluoxetine or Prozac, I think there's a wait of 5 weeks because of its very long half-life. Not only just the parent compound fluoxetine, but norfluoxetine, which is the principal metabolite of fluoxetine, has a half-life of about 7 to 15 days, and it can last in for months actually in the system. We did a study when I was in Wichita, and we found that the levels of fluoxetine were detectable until at least 3 months. Yeah. So let's move on. So the other scenario is that when you switch from monoamine oxidase inhibitor to any other antidepressant, especially SSRI, what are the guidelines? So the guidelines are kind of you should wait for 2 weeks. It also depends upon the half-life of the monoamine oxidase inhibitor you're switching from. For example, short half-life monoamine oxidase inhibitors such as selegiline, you might get away with a shorter period of waiting to start the new medication. But with others which are relatively longer half-life, such as phenelzine and tranylcypromine, relatively speaking, I think 2 weeks is a safe period. Now, before I move on, I think what I would like to discuss is a little bit starting the adverse effects of SSRIs. I actually consider drug interactions as the adverse effects of SSRIs. As we just discussed in one of the earlier slides when I was talking about the mechanism of action of SSRIs, which is rather not that selective, as you must have seen that slide, that it has so many different sites of action SSRIs can have based on the plasma levels and the dosages. We were talking about how many different sites SSRIs can affect. And this is one of the sites which actually results in maybe some really fatal outcomes sometimes, which have been reported. Fortunately, not that frequently, but they have been reported in patients because of drug interactions in which SSRI inhibits a cytochrome P450 enzyme, and that results in the elevation of plasma levels of the co-administered drug, and that can cause toxicity from that drug and cause problems. So let's start a little bit. This is a whole lecture by itself of drug interactions, but I'll try to do as much as I can during this presentation. So we know that fluoxetine, if you remember from the earlier slides, Prozac or fluoxetine actually inhibits 2D6, cytochrome P450 2D6, and cytochrome P450 3A4. These are the two enzymes which probably are responsible for majority of psychotropic metabolism, the psychotropic drugs which we use in clinical practice. And these two enzymes are extremely important. And when you use fluoxetine and it inhibits two of the most important enzymes, you need to be really careful in examining what are the other drugs you are giving to that patient, because that can be disastrous. Fluoxetine also inhibits 2C19, but let me tell you, this is not a equal potency effects. Fluoxetine actually inhibits 2D6 potently even at 20 milligram, but at 40 milligram, it starts to inhibit other enzymes, and at 60, it can inhibit all three, 2D6, 2C19, and 3A4. So that's an important point that you need to remember, that it is a dose-dependent effect of fluoxetine. And if you know the substrates for these three enzymes, and you're increasing the dose of fluoxetine, you can see what you need to do, right? Zoloft or sertraline is, relatively speaking, is a quite weak inhibitor of 2D6. And that is one of the reasons why sertraline or Zoloft became quite popular, because at least you don't have to worry about major drug interactions with other drugs. That is a highlight of sertraline. And there's another drug which we'll talk about, which is also a very safe drug, SSRI, I mean to say. Paroxetine is a very potent inhibitor of 2D6, and just like Prozac or fluoxetine, they are both very significant inhibitors of 2D6. But the good thing about paroxetine, relatively speaking, is that paroxetine has not been shown to inhibit other cytochrome P450 enzyme systems. So that is something which even if you go higher on dosages, you don't have to worry that much about as you would worry with fluoxetine or Prozac. Fluvoxamine is the another SSRI, And I think we did speak about fluvoxamine, that why I am talking about fluvoxamine in an antidepressant lecture, because it is not approved by the FDA as an antidepressant. Again, the same old topic, I'm quite passionate about this, that people talk about evidence-based medicine. Evidence-based medicine should be the gold standard, but it's not everything, because there's a lot of information out there which actually challenges evidence-based medicine concept, because fluvoxamine failed the trials in depression does not mean that it is not effective. Uh, the main reason why fluvoxamine failed is because of the poor design and high placebo response in the study, but that does not mean that it is not effective in the treatment of depression. So I would always consider it as antidepressant among SSRIs. So that's the important point. Actually, fluvoxamine may be one of the best in terms of causing sexual dysfunction. It is the least problematic in that. I think we discussed that in the previous slides. But fluvoxamine is a major problem in terms of drug interactions, because it inhibits cytochrome 1A2, which actually is not affected by the other SSRIs. So this is something new with SSRI, that fluvoxamine is the only one which inhibits 1A2, and then 2C19 and 3A4 almost at some similar dosages. Not exactly. The potency, the binding affinity is a little bit different, but these three enzymes can be inhibited substantially even at the therapeutic dosages of fluvoxamine, which ranges between 150 to 300. So we need to be careful. So Prozac and fluoxetine and fluvoxamine, which is the trade name is Luvox in America, are the most concerning in terms of drug interactions. Which is the one which is quite safe as well as sertraline, citalopram. It is also a weak inhibitor of 2D6, and that is why sertraline and citalopram and S-citalopram shares that property, because it is a half molecule of citalopram, or an enantiomer of S enantiomer of citalopram. So I think it shares those same quality. So we don't need to worry that much about drug interactions with the citalopram and sertraline. Vilnafaxine is a SNRI, but I think this with this slide, since it's here, we can actually we can talk about this later. Okay, so let's talk about 2C19. I already told you about some of the things which are going to be shown by this cartoon, but the visual memory is a little bit better, so you might remember this a little bit better. So 2C19, do you remember which SSRI inhibits 2C19? We just talked about it, right? Fluvoxamine. And I need to add fluoxetine at high dosages, because that also inhibits 2C19, just to be complete. And then 1 and 2. The answer is the same, fluvoxamine. And fortunately, we don't have other drugs which inhibit SSRI, I mean to say, which inhibit 1 and 2. 1 and 2, I'll tell you about the substrates. So that is important. Yeah. So potential clinical relevance of inhibiting 1 and 2. That's exactly the slide I needed. So 1 and 2 actually metabolizes theophylline and caffeine. Theophylline is mostly present in the tea, which we Pakistanis and other people drink a lot from South Asia especially. So theophylline actually is metabolized with 1 and 2. So don't think that if you are using a drug which inhibits 1 and 2 and you feel your tea is really potent, that day, that there could be a reason for that some drug is probably inhibiting the metabolism of theophylline. Thing is for caffeine, but caffeine is much more potent in its stimulating effects. And so, for example, I use this example quite a lot when I teach residents, is that if an older adult is using maybe 2 cups of coffee a day, and he or she is started on fluvoxamine, that 2 cups of coffee can become about 4 cups of coffee. And if has a risk for arrhythmias, that can really be problematic in that patient. So that's a practical value of knowing these substrates. There are others too. For example, clozapine and olanzapine, which are quite frequently used antipsychotic medication, especially olanzapine is probably the #1 atypical used in America, if I'm not mistaken. I saw the data quite few years back. So it's very important that if you use a drug like fluvoxamine with these 2 antipsychotic medications, you need to be extra careful because a lot of side effects mediated by these 2 drugs are actually dose dependent. And with clozapine, you have to be really serious because clozapine has really, really clinically fatal, clinically serious adverse outcomes, which are, thanks God, rare, but they can happen. Paroxetine. So let's see, paroxetine for 2D6. This slide is in reverse, but you get the point. 2D6 is potently inhibited by paroxetine and fluoxetine. What is the implication, clinical implication? Let's look at the substrates. Even before that, I think the switching idea, the point I made earlier in the slide, is that if you are switching or you are adding a tricyclic antidepressant with a fluoxetine or paroxetine for that reason, you nearly need to have therapeutic drug monitoring of the tricyclic level, especially the secondary amine tricyclics, which are primarily metabolized by 2D6 and are hugely impacted by a substantial inhibitor of 2D6 for that case, for that reason. And so patients can die from torsades. Certain cardiac death can occur, especially with disipramine and nortriptyline, which cause QTc prolongation. So actually that is a standard of care. Not even without using SSRI, you have to do the therapeutic drug monitoring for these 2 antidepressants. But with SSRI and other drugs which inhibit 2D6, it becomes a requirement, absolute requirement. And the liabilities can be huge if you don't care about this. So the codeine story is out there now. We knew this many, many years back. And when we used to tell the primary care physician residents who used to come and be trained by us, including the psych residents, they say, Dr. Shad, what are people talking about codeine losing its efficacy if you're giving it with SSRIs? Very, very interesting idea, because I think we need to be familiar with this concept. So basically, we need to know that if a drug is active as a parent compound, or it is active, it is a prodrug, and its metabolite is the active compound, right? Very important concept, because otherwise we won't be able to understand what is happening here. So codeine is actually a prodrug. It is not an active drug that much. The primary effect, the analgesic effects, and the euphoric effects, I guess, associated with that, actually come when codeine converts into morphine through 2D6. And if a drug is inhibiting 2D6, such as Paxil, paroxetine, and fluoxetine, what is going to happen is that codeine is not going to convert into morphine, and the patient will say, Doctor, have you given me a placebo? The drug is having no effect. And there you go. You're sitting in your office and you're thinking, oh, here comes a big addict, and you started to develop negative countertransference against the patient without any valid reason for it. Although there should not be no reason for negative countertransference, we should be better trained than that. I'm just making a point. So basically, remember that if you are giving a drug which inhibits 2D6 and stops the conversion of codeine into morphine, then the patients are going to miss on the analgesic effects. So this is not the only prodrug. There are many others. The other example comes to my mind while we are discussing it is extremely important. Tamoxifen. Tamoxifen is also a prodrug. It is converted into active drug by cytochrome enzyme and we need to be careful about those agents which actually modify the activity of the cytochrome. Beta blockers. So 2D6 is really an important cytochrome enzyme because it metabolizes a lot of very important medical, especially psychotropic drugs as well, a lot of them, including tricyclics, as you know, including antipsychotic medications. Those are the two huge classes, right? And then the beta blockers. And then the xanthine derivatives like caffeine and theophylline. So beta blockers are metabolized by 2D6, and if you give SSRI, which inhibits 2D6, simply you can understand what can happen. There can be a heart block, and the patient may die from it. So we need to be extremely careful. Now 3A4. Now this is 3A4 is the most abundant cytochrome enzyme in human bodies, and based on one study, actually it metabolizes about 60% of all drugs which undergo biooxidation via cytochrome enzyme systems in human bodies. So this is really one of the most important cytochrome enzyme. And one of the fascinating thing about this enzyme is that it also resembles in a structure, at least, with a P-glycoprotein, which is a transporter protein. And I think we did talk about a little bit about that. We'll touch on it again because it's a very important transporter. So remember that most drugs which alter the activity of 3A4 can also alter the activity of P-glycoprotein, which can be extremely consequential, especially in the GI tract, where, like for example, grapefruit juice inhibits 3A4 as well as P-glycoprotein, and that's why there can be a robust increase in the levels of the drugs which are absorbed in the GI and going to the system. But those are effects which don't occur over long-term of period, only when they are clinically significant if the drug given is in the vicinity of time when grapefruit juice was used. So 3A4, fluoxamine. We talked about that. Fluoxamine inhibits 3 cytochrome enzyme systems. One of them is 3A4. And then remember, fluoxetine. Vilazodone is a drug which is not SSRI, but it is like SSRI. It is actually a 5-HT1A partial agonist as well as serotonin reuptake inhibitor. And I think we talked about that in the lecture when I was talking about the mechanisms of different antidepressants. So I'm not going to, but these are the three. Vilazodone is a substrate for 3A4. So remember, there are primarily speaking 2 types of inhibitors. One set of inhibitors called competitive inhibitors, and the other one is called the non-competitive inhibitors. So vilazodone, any drug which competes for an enzyme for its metabolism, will be a competitive inhibitor. Effects of SSRIs on sleep. Unfortunately, I don't have any recent. I searched again and again, but couldn't find any recent study. This is all back in 1994. So unfortunate, but the data speaks for itself. So when you look, and at that time there were only 3 SSRIs available. So you see why there are 3. Prozac, fluoxetine, Paxil, paroxetine, Zoloft, sertraline. So if you look at the 3 major parameters of sleep on which the sleep efficiency and quality of sleep is assessed, those are continuity of sleep, slow wave sleep, and the rapid eye movement sleep. And so these 3, if you look across the board, you see some differences here, right? Paxil comes out as one of the most problematic in terms of continuity and the REM sleep, whereas Prozac has some problems, but I think Zoloft appears to be one of the best. And the argument I make is that because it has maybe slight dopaminergic activities, especially at higher dosages, as we discussed, but that could not be the only reason. There may be other reasons we don't know. But here are the data, so that you can look at it, right? Okay. And Paxil I think one of the things which we think why paroxetine may be really most problematic is because remember anticholinergic effects actually may be REM suppressor, so that may be one of the reason why because acetylcholine is extremely important in inducing our REM sleep. I'm sorry, acetylcholine, right? Weight gain. Weight gain is actually another thing which a lot of people actually they know this. I'm sure they have read about it, but in their clinical practice, they don't they may not base their selections based on the weight gain issue. But this has become quite a relevant issue in psychiatry when you're using antidepressants with antipsychotic medications quite commonly, and along with mood stabilizers such as Depakote, which also causes weight gain, it becomes a huge issue. Piling up drugs, which actually may increase the risk for metabolic syndrome, not a good idea. So please look at this data and remember that which one of them is the most problematic, and try avoiding using that SSRI, especially in combination with drugs which cause weight gain. So, so this was a study in 2000, not a new study, but that's what we have. Because after that, we actually didn't need many studies to see the effects, because some of the effects of these SSRIs on weight gain were replicated in another study. I'll show you that too. So for the first time, they actually conducted this study looking at the changes from baseline after weight gain over 6 months between three SSRIs, fluoxetine, paroxetine, and sertraline. Look at the results. Amazing. 4.2%. And what is the definition of weight gain? 7% or more than 7% of baseline body weight. That increase is labeled as, I don't know who started that, but that has become the convention in clinical trials to use that parameter or threshold. So sertraline, 4.2% of the patients had that. 6.8% with fluoxetine, slightly higher. But look at paroxetine, 25.5%. That's huge. So we need to remember this. The study which confirmed, replicated some of these findings was done by Forest Lab, who actually came out with citalopram because they wanted to show that their drug is also different from paroxetine. So they did this study for marketing reason, obviously. And so they did this trial, which was well-designed trial, double-blind randomized 6-month study. It actually showed that citalopram was 4% and paroxetine was 22%. So we are close within 22 to 25 with paroxetine replicated. Discontinuation symptoms. This is also a big problem with SSRIs. Some people used to call it withdrawal symptoms. That's not a good terminology, because then you're calling your drugs SSRIs as addictive drug, because that is a concept which is used in addiction, right? So we prefer to call them as discontinuation symptoms, just to prevent from that misperception, right? So discontinuation symptoms, again, I think it's not rocket science. People who know a little bit of pharmacology, basics of pharmacology, actually would know that it primarily depends not just the half-life of the drugs, but primarily on half-life of drugs. There are other factors too, which if we get a chance, we'll discuss. But discontinuation symptoms is primarily the expression of the half-life of a drug. So what are the symptoms? So you can diagnose it in clinical practice. Very confusing, because it can look like a serotonin syndrome. It can look like a low-grade catatonic crisis, like neuroleptic, although that would be a very easy differential. And so you have to be careful. So this discontinuation symptoms, one of the pathognomonic finding, which actually I have noticed in some of these patients, is this electric shock-like feeling. If you can remember that, just that one, you may be able to really identify a lot of cases. of discontinuation symptoms. But flu-like symptoms, fatigue, nausea, headache, insomnia, nervousness, and paresthesias, but electric shock feeling is important. And these effects may also occur during treatment. Um, how can they occur during treatment? Okay, I'll tell you. I wish this was interactive action session, because then I can ask questions. That's the style I like the most. Unfortunately, in a presentation like this, we cannot do that. Yeah. So they can definitely occur during treatment. Why? Because the vulnerability of patient may vary with their diet, with their other things, activities they are doing, or the concomitant medications may have some serotonergic effect which they are not aware of. There many drugs have a little bit of serotonergic activities. So any one of those reasons, and then you might increase the dose of a single SSRI, and it can result in I'm sorry, I'm talking about serotonin syndrome. Yes, I apologize. So these discontinuation symptoms, it's opposite side of the story. Sorry, I will talk about what I just said with the serotonin syndrome. Yeah. So discontinuation symptoms actually occur during treatment is a reflection of whether you give a drug which induces the metabolism of the previous of the SSRI, which will result in decrease in plasma level of that drug, and that may result in discontinuation symptoms, as well as somebody may be non-compliant. They may forget to take the medication for a few days and develop discontinuation symptoms, and then especially for those clinicians who don't ask about whether you took your medication or not, they for the first time they realize, oh my God, my patient may not be taking their medication, which actually every clinician's responsibility to ask the patient. What are the different frequencies of discontinuation symptoms with different antidepressants? So you can see that clomipramine, which is not SSRI, but just as a reference, look at the discontinuation rates from clomipramine is about 31%, which is the biggest number here. With paroxetine, 20%, with fluoxamine, 14%, and with the Zoloft or sertraline, only 2.2%, and fluoxetine, 0%. So this is, again, quite self-explanatory that why this is happening. Fluoxetine has the longest half-life metabolite, at least. Even the parent compound has a long half-life, but norfluoxetine especially is very protective against the discontinuation symptoms. So when you are switching fluoxetine to any other antidepressant, despite the precautions you take to prevent serotonin syndrome, but if there is a non-serotonergic drug which you are converting to, you don't have to worry about stopping fluoxetine immediately all at once, which I never recommend with any other psychotropic. So that's a rare kind of suggestion. Okay. So paroxetine, why paroxetine is the highest among SSRIs? Because paroxetine has a shortest half-life and also is a auto inhibitor, which means that inhibits its own enzyme. It inhibits 2D6, which actually metabolizes it as well. So that is called auto inhibition. And that auto inhibition, actually, when you stop the drug, the auto inhibition is also discontinued. The effects of auto inhibition or 2D6, and that is the reason why the 2 to 6 activity may increase after its discontinuation and may cause long-term discontinuation symptoms, because it takes a little while. So very important points to remember, that when you discontinue paroxetine, be very, very, very careful. Actually, there are studies in which discontinuation of paroxetine over weeks, even that has resulted in problems. So before I move on, I'll just make another factor which is extremely important in discontinuation symptoms, and that is if you have an active metabolite. If a drug has an active metabolite which has a biological resemblance with the primary action of the drug, then that's protective as well. Paroxetine does not have any active metabolite, so that is another reason why paroxetine is bad. Why Prozac is not, fluoxetine is best because it has a very long acting active metabolite, right? Think about it. Zoloft has a somewhat active metabolite, which has about 16 to 20% of its biological activity of the parent compound, N-desmethyl sertraline, which can be protective. So that is why the rates are a little bit lower. So there is, when I'm talking about mechanism-based learning, right? And people might be wondering that why I'm so crazy about mechanism-based learning. The most beautiful thing about mechanism-based learning is that a lot of these things you can define if you really know the pharmacology of the medicine, of the drug you're talking about. Like the things I'm explaining to you, I don't need to provide any further support. I think the support comes from the half-lives and the discontinuation and the active metabolites. That makes perfect sense with the clinical data. And that is the highlight of our field. Sometimes we see that. It's not often, but you see that. To continue the discussion of half-lives, you see that there are differences, as I was just stating earlier, in the half-lives of the SSRIs. So you can see, as we talked about, citalopram 1.5, 1.5 day, fluoxetine 2 days, and so forth. But the main reason of this slide is to tell you that if somebody has a cirrhosis of liver, then how much impact that would have on the half-life of these drugs. For example, there are drugs which are not affected that much, but there are drugs which are affected much more significantly. Look at sertraline, 1 day to 2 days. That is not as big as from 2 to 7 days with fluoxetine, and citalopram, slightly more, not as bad, 1.5, 1.5 days, so 3.5 days, so forth. So this is a good information to have in patients with cirrhosis in whom you want to use SSRIs. One important thing, though, is a lot of people kind of become very reluctant to use these medications, even in patients who don't have cirrhosis. They have a compromised liver function, but it is not that much compromised to cause any significant problems with these medications. Remember, 80% or more than 80% of the loss of liver function results in these kind of concerns. Before that, liver is, God has given us a big, large organ, and there's a reason for it. There is a lot of capacity and reservoir. Renal impairment. Citalopram, we don't have a studies, but with fluoxetine, and sertraline, there are no concerns. Paroxetine again comes out a little problematic because it can decrease GFR and can increase plasma levels of the of itself. Leading to black box warning. Very important. A lot of people ask me, the discussion is dying down though, but initially it was one of the hottest news in the media that, oh my God, SSRIs cause suicidality, right? It was a big concern. It took us several years to provide some logical reasons why this could be happening for the public to calm down. But this was a huge problem. But there are a couple of things. The reason I added these slides is just to give you a couple of pointers, which are clinically very important. So if you look at this slide, you see the odd ratio for suicidal ideation and behavior and the basis of the age group, right? So on the y-axis, you have the age groups, and odd ratios are on the x-axis. What do you see? Less than 18 years, the biggest odd ratio, right? And it decreases as you go down, as you go up on the age. But 18 to 24, 18 to 24, before 18 and up till 24, maybe the biggest risk age group for SSRIs. I'm not going to talk about the reasons why this might be happening. We already, because of the time. FDA advisory in 2007. That is the reason why.
Sorry to
FDA
cut
actually,
you, Professor Shah. I think
Yeah.
would be interesting to know the reason behind why suicidality increases in a certain group with SSRI, but not in the other age groups.
Okay. We'll do that since Yusha is asking.
No. I am also interested because it is under 18. So you just see in the child and adolescent the highest group.
Yeah, the explanation is actually not scientifically confirmed, but most people actually buy this. So I'll give it to you. But I think I just wanted to say that the reason I was skipping is, I apologize, but the reason I was skipping it is because we are already, this is the sixth lecture and we have not finished with antidepressants. And if you're okay with having 8 to 10 lectures or maybe more than that, that's fine with me. Yeah, so let's go to the reason. So the primary reason they actually talk about, which was explained in many review papers and was discussed in the FDA meetings to actually calm down their anxieties about this and other people, is that when depression, the classical depression, it does not have any energy. The classic depression, they are just lying in, they don't have energy to even act on their suicidal impulses. They are completely anhedonic, they are completely asocial, they're completely avolitional. They are just, they don't have any energy. And what happens is that when you give a drug like fluoxetine, which is highly activating, it actually does not address the suicidal symptoms or the depressive symptoms from the very beginning. We all know that. So the first thing which comes is the energy boost, even before the patient starts to feel better. And that is one of the reasons why they think may be responsible, that there is a will, but there's no energy. And fluoxetine and SSRIs provide that energy, despite showing any significant improvement in depressive symptoms, which is highly unlikely. We know that, right? So that is one reason which has been given. But remember, even a bigger reason on a broader spectrum answer is that, look, we are talking about a very complex brain system, right? Some patient, and we discussed this in some of the last lectures, that some patients actually may not agree with a serotonergic boost. As we were talking about tianeptine, which is a serotonin reuptake enhancer approved in Europe for the treatment of depression. So all sort of complexities and confusions across the board. So I think it is not highly unlikely that in a minority of patients, you might see actually increase in suicidality, regardless of any the reason I gave you earlier. These are systems, and there are reports with other agents as well, not even psychotropics. For example, everybody may know this, that long-term use of beta blockers can cause increased depression and suicidality. So it is just kind of, although it has its value, people need to know these things. There's always this media hype about things, oh my God, what's going on with these medications? Should we use them or not? Does that answer, Yushe?
Yes, it does. Actually, I have read the same thing over internet as well, but is it like, did FDA buy it, or are there any proper studies conducted on this
No,
energy
FDA is
hypothesis?
not. No, FDA is not buying it. They have not removed the caution because they want to play it safe. It's easy for them. They need long-term, double-blinded, randomized studies which can show, which actually we're talking about billions of dollars. So nobody is going to do that because look what happened. Actually, the use of SRS have gone up now. Even maybe because the population is increasing and more patients are getting treatment. But I'm just making a point. The concern is over. I think, in my opinion.
Yes, it
Yes.
is.
So FDA didn't buy it. Yeah.
And why is that age difference? Like, definitely energy decreases in all age group. Why is it like that?
Great question. Yeah, great question, Yusha. I like your thinking. You always ask these questions, which actually brightens my day because, I become sharp too. I have to know these reasons. Otherwise, you're going to kill me, with these questions. I'm glad that I know the definite. I don't know the definitive answer, but I can put up a hypothesis that look, the brains of younger age group, they're still developing, and the time when the pruning occurs, before that lot is happening, and they are much more vulnerable to the effects of the neurotransmitter changes in their brain, especially the negative effect of serotonin and dopamine may be actually one of the main reasons. I don't have any proof to give to you, but I think about these things, and I think dopamine system, which is the last to mature, actually, as a matter of fact, it matures the lit. It is the last to mature in human brain around about 22 years of age. So you can imagine that is if you are changing the chemistry of a growing brain, that might actually carry more risk. And I don't have any other explanation. Okay.
Just one more
I think
question,
we
Dr.
should,
Shah.
no, I think we should
Fazia,
let him
you
move.
were asking. Yeah.
We will do the question answer in the end.
Okay,
I think
sure.
Okay.
we continue the lecture.
Okay. Uh, so Fazia, are you okay with that
Yes,
explanation so
yes,
far?
yes,
Okay.
yes.
Okay.
We have read.
Okay.
Thank you.
Okay. Yeah. So another kind of a slide, which is a little bit more informative on the half-lives and the pharmacokinetics of SSRIs. We already discussed the half-life. Time to steady state. We already know that fluoxetine needs a lot of days to achieve the steady state. Just to tell you, some of you who don't know, that the steady state is about 5 half-lives. So, for example, if a half-life of a drug is 1 day, then it will take 5 days to achieve the steady state. Okay, very important point, because a lot of people talk about steady state levels. Um, the proportionality between the level between the plasma level and the dose, and I think that can be better phrased as linear pharmacokinetics, because that's basically what it means. So which of the SSRIs have linear pharmacokinetics? And then I'll tell you what is the benefit of having a linear pharmacokinetics. Citalopram, yes, it has linear pharmacokinetics. Fluoxetine, little questionable because it's a very long half-life. So it's difficult. It's much more complex than that. Fluvoxamine, a weak no. It has non-linear, but may not qualify for a significantly non-linear pharmacokinetics. Paroxetine, completely non-linear. Zoloft is linear. Remember, we talked about the one of the earlier slides, that the levels were increasing based on the increase in dose, and they were correlating with each other. That's linear pharmacokinetic. And why that is important? Because you can predict that I'm increasing this dose by this much, what levels patient is going to have. So I can look at the data, which levels are needed in terms of efficacy, if that is available. For a lot of drugs, it's not. I'm just making a point. Predictability, and the predictability of the side effects as well, because if the plasma levels are disproportionate to the drug, the events of the adverse events will be disproportionately higher. So that is another important point. And then we talk about the active metabolite, which actually we discussed in the discontinuation topics, and the inhibition of the cytochrome enzyme systems. So sertraline has a metabolite which actually may have some ability to still inhibit 2D6, but paroxetine actually does not have any active metabolite. So that is a little bit confusing. So let me read. Active metabolites in terms of comparable in vitro potency to parent drug for inhibiting specific enzymes. Yeah, paroxetine should not be there if they're talking about active metabolite. Anyways, so let's move on because this is a little bit confusing. I don't want to confuse you. Need to change that. Okay. So these are the changes in half-life. We'll skip that. So yeah, this is actually a very, very important slide. And this is the last of this section on SSRIs. So please try to pay attention on this one. On the y-axis, you have the survival. And this is in relation to suicidality with SSRIs, as we were discussing. Survival is on y-axis and days of follow-up are on the x-axis, okay? What do you see? So the lower the survival curve, the worse the survival rate, right? So this is a survival analysis. This is a Kaplan-Meier curve, right? Which we call in statistics. So basically, when you look at the uppermost, lines, you will see that those are for the age 25 to 64 years old patients. Modal dose, which is conventional dose, and high dose, not much separation there. But when you go to 10 to 24, even the modal, the conventional dose results in bad outcomes, worse out, more worse than usual, as you see in age 25 to 64, right? But look at 10 to 24 high dose. That's the worst. Now, we see that giving even a conventional dose can be problematic, as we just saw the data. But giving high dosages actually might be much more problematic than the conventional dosages. Now, I am going to again brag about the point I have made earlier. What you remember, linear pharmacokinetics, the sigmoid curve, the flat dose response curve. Another support for that comes from this study. And this is a huge one because it results in suicides, right? Okay. Now let's talk about, should we continue, Fazia and Yushe,
I think
or we
Professor
should stop?
Shad, I think we should be open for some question answer session, and
Yeah.
then
Okay,
later on
okay.
we can
Yeah.
So
continue.
we can
So
start SNRIs next time. Okay.
next time, yeah. So thank you very much, Dr. Shad, for such a mind-blowing lecture. The tips and the points that are not available in books, even books, and the understanding of these curves and everything. Thank you so much. So I would like to invite Dr. Noman Ashraf uh, for his feedback or any additional comments he would like to add.
Thank you, Fauzia. Yeah, Dr. Shah, again, wonderful lecture, and it's always good for me to learn from you and sort of you have a lot of experience to just hear from you, and the way you explain it's just great. It was wonderful. I'm not sure if there is anything that we need to expand on. I think Dr. Shah already touched upon the SSRI issue, that when you started initially, it takes for like 6 to 8 weeks to kick in for the therapeutic action, but you get the side effects first. So like akathisia, when it comes on, people have energy, and if they're suicidal, that's when they act on it. So I think that's the most reasonable explanation of that event that you would find. Overall, wonderful lecture, but I'm here if anyone wants to have discussion.
Yeah. Thank you, Noman. Thank you so much.
Okay, if anyone else want to come join in and have any question, please.
I'll take the liberty जब तक कोई और हाथ खड़ा नहीं करता for the question. So, Professor Shah, I was wondering that most of the trials that has happened with the SSRI, and upon those trials, they have decided about the suicidality issue. In all those trials, they really haven't focused on different moderators that could have confounded the results. For example, not all the depressed patients within a trial would have the same suicidality level at the beginning of the treatment. Similarly, not all the patients, there might be some personality disorder patients, and we know that the patients having affective dysregulation, especially in borderline personality disorder, their affective dysregulation or sometimes their self-harm behavior exacerbates in presence of antidepressant. So could it be that these trials were not adequately powered to find different subgroups within those one big, large depressed group?
Yeah, you share again a great question. My focus was on neurobiological stuff, but I think your point is well taken. We should always, while we are talking about psychopharmacology, we should not forget about the other side of the picture, which is the psychosocial environmental effect. For example, SSRI, despite increasing energy in children especially, may not induce suicidality if there is high quality support and love available from the parents, and the social environment and the financial environment, and is stress free. So environment plays a major role. And unfortunately, the problem is, you say that these studies are already billions of dollars, right? They take on average 10 years, and one drug may have to spend $1 to $2 billion, and that price may be increasing even now, because there are several molecules on the bench, and they go from one to the other and have to restart from scratch if something happens with the first molecule. So I have communicated with the industry people quite a lot, so I know that it is extremely difficult, because they defend their higher prices of the medications based on what I'm saying, that they wait patiently, and then there's no guarantee that the medication will be approved. How many trials you have seen gone negative? I don't want to be here as a advertiser or supporter of a pharma, but I think we need to be fair in our judgment sometimes. So I'm going on a tangent, but coming back to your answer, Yushe, is that is that you know the clinical trials, the primary goal of the preclinical trials to get a drug approved by the FDA is to get the drug approved by the FDA, right? There's no other reason, and they find the easiest way of doing it. And what they have, based on the FDA guidelines, they only have to produce two positive studies, only two positive studies. There are hundreds of negative studies, but if they can prove, they can bring up two positive studies showing differentiation between placebo and the active drug, they can get the drug approved by the FDA, unless there are extreme adverse effects, which actually is the other reason why FDA can reject a drug, right? So why are they going to spend billions of dollars in looking at the environmental, which actually only going to confound the effect of their study? And their drug may actually fail because of those, because when you control for those, the drug may lose efficacy or may increase efficacy. Either thing can happen. So you say it's not easy. Do I answer your question? Yeah.
Definitely, Professor Shah. Thank you so much. Yes, Dr. Noman, you can.
I'll agree with what Dr. Shah said. I think so. And the point that you raised. If you look at the Katie trial for schizophrenia, that was the main struggle back then. So we have all these pharmaceutical designed studies, and there's a bias of cherry picking the population, because again, as Dr. Shah said, if you're spending so much money and you need to have a successful trial, you kind of come up with the inclusion exclusion criteria that eventually should work in your favor, right? So then they said, okay, why don't we go to the government and had NIMH give us the money and have a public trial, and the inclusion exclusion criteria is going to be very broad. So like go to the real patient population, enroll them, and then see what we get. So you look at Katie trial, back then everybody was saying, well, second generation antipsychotic, we should use that. They're more effective and all that, and they're very expensive. They picked chlorpromazine from the first generation, and it showed they were as effective as the second generation. So the results were very surprising. So this is, but it's hard to do another Katie because you need a lot of money, and who's going to fund it? How far government is going to go to fund this? So, but that's where what you are raising is the skill to critique an article. You always want to know who is funding the article, what is the source, which journal it went to, who were the peer reviewed people who reviewed it. So I think this all goes into that, so you can come up with the credibility of the article. But I think it's an important issue to raise. Thank you.
And I would also, add to that. the SSRIs are in demand currently. I mean, even this black box warning, the suicidal ideation or anything, uh, they are in demand. If you go to public, they are going to have a trial in favor of SSRIs. I don't think so. They are going to, I mean, having a trial currently, especially currently. I mean, what we are seeing in our outpatient, almost every patient, they are coming, they are already prepared for I mean, they have all the knowledge for SSRIs, and they even we tell them about this black box warning, they say okay, fine.
Uh, Professor Shad, I think if there are not any other questions, I think I would
I
like.
think there was one question from okay, no. Okay, yeah. Dr. Shad, would you like to say anything else?
No, I think uh, you know I think it's been, at least I believe, I may be biased, that this has been going smoothly. For such a good organization, I wanted to thank Fauziya, especially because she has done such a great job in making the brochure and advertising it. It is really commendable work from you guys. And Yushe, you're also quite an active participant, and you really appreciate you guys. And Noman, thank you very much for joining us. It was nice to have you here today. Thank you so much. And if there's
Thank
nothing else, we can, yeah.
Thank you very much, Dr. Shad.
Yeah.
Most of all, thank you very much for your time and all this effort.
Yeah.
We really appreciate that. Thank you
Yeah.
very much,
Thank
everyone.
you.
Thank you
And
so much, Dr.
Okay.
Shad.
Khuda
thank you.
Hafiz.
Allah
Allah
Thank
Hafiz.
you.